And I'll tell you why. Don't leave. I wanna talk to you about our fears, and you're leaving. So it's a very cozy environment here. So it's correct. You know, we have some fears as surgeons. One is bronchopleural fistula. The other one is patients with borderline lung function. Okay. What is the definition of borderline patients? What do we want to avoid? What we want to avoid for the one we operate on, that they have a mortality rate for lobectomy and pneumonectomy which would exceed the accepted rates. But also, especially in this country, we want to make sure that the patient we operate do not develop lifetime complications or disability, which are expressed by worsening dyspnea or oxygen dependency, or, again, much more in the United States. Our borderline patients, the one that if we operate on them, are going to spend a couple of weeks, 3 weeks, a month in the ICU, end up with a tracheostomy, or we dismiss after 4 days or 5 days and keep on coming back and being maybe admitted overnight in the ICU and die. So how do we select them? How do we know who are the patients with borderline function? The literature is filled with a series of spirometric criteria. And I'm going to show you just some of them. And obviously, and one question I would like to ask our colleagues radiotherapists, whether they ever done some serious questioning of their practice with regard to some patients with a PPO FEV1 of less than 35%. I don't know. But this is not enough. It's been proved, and I'll show you in a while that the spirometric criteria are not enough most of the times. So we as a thoracic surgical community, came up with the idea of a cardiopulmonary exercise testing with high technology ones, but also low technology, and with decreasing thresholds for operability. And why is that? Well, this is my work, very humble work. Just to show you that where the arrows are is where you expect poor cardiopulmonary performance, and the bluish data of the VO2 max less than 10 milliliters per kilo per minute should be only there. But if you look at the reality, you have bluish areas, other points of this isometric diagram. That's exactly where the FEV1 or DLCO or both are acceptable, both in terms of raw values, but also percentage-wise. And if you use the decreasing criteria of VO2 max, you're able to select more patients that are beginning to be deemed operable. If you use 15, you see that you're pretty much in my series, you could have a sort of a split decision in terms of operability. Then you recruit more patients with a 14 milliliters per kilo per minute cutoff and end up even better with a lower threshold. So what is the strategy to identify these patients? We can refine the preoperative assessment. We can adopt uncritically national or international guidelines. We can adapt the parenchymal resection to the anticipated risk. We can ask the patient. We can say, what do you think about it? Are you ready to withstand a risk of mortality or to have a long-term disability? We can establish a pre-op rehabilitation program with a smoking cessation policy in it. And last but not least, we can consider a minimally invasive approach and exercise, a great deal of common sense. So very quickly, refine preoperative assessment. These are the results from two very famous randomized trials in the US. ACOSOG Z4032 and Z4099. You look at the criteria for high-risk patients, less than 50% of predicted FEV1 and DLCO. Obviously, if you use those criteria, the difference between high-risk and normal-risk population, both for lobectomy and sublobar resection, is absent, zero, no difference. So this is not a good criteria. We can use other testing. We can use maximal inspiratory respiratory pressures. We can use, like Alex Brunelli demonstrated, a V/VCO2 slope as a measure of ventilatory inefficiency. We can use an exercise DLCO, and we mix all the kind of indexes and scoring that we can possibly use. We haven't quite found the right way to do it. And that's why many of us, unfortunately, I would say, uncritically adopt national and international guidelines. Why? Because like this ERS-ESTS, I was involved together with Gonzalo, Alessandro as a first name. We can have a cascade of decision-making in the decision-making process, which lead us almost without effortless to the decision. Or we can apply a tripartite risk assessment, and instead of a vertical line of thinking, we can have a horizontal one, which give equal dignity to the possibility of a postoperative cardiac event, of perioperative death, or disability in terms of dyspnea. And obviously, what is the criteria? The criteria that are being used to define the moderate to high-risk population is a PPO FEV1 less than 40% and the DLCO less than 40%, which obviously leads to the need to having more thorough functional assessment with split function or with CPAT. That sounds bad. Adapt the parenchymal resection to the anticipated risk. It looks like we are ready to strike compromise with our practice. This is not exactly what I want to say. I was leading a task force within the Society of Thoracic Surgeons looking at the role of surgeon in CT screening programs. And I like this definition of what we should do. The surgeons should should try to recommend the least parenchymal resection compatible with current diagnostic and oncologic principles performed through the least invasive surgical approach. So the least parenchymal resection, the least invasive surgical approach, which means translating around everyday clinical practice, once we assess with whatever method we want the cardiopulmonary risk, you have to treat central lesions by lobectomy or segmentectomy, and you can still use wedges. Hello. You can still use wedges. It's been proved by authorities in the field, by recent retrospective studies, that as long as you do quality surgery, because that's the point, it's not the procedure itself, it's the way you perform it. So it can be better than the SBRT. It can be much safer than lobectomy for selected patients with very early stage. But again, we need to know what we are doing. It's been too long that we treated wedge resections as a sort of the last resort. This is not the case. As long as we add a very good lymphadenectomy and we really calculate the margin. And there are ways, obviously, for expediency. I cannot go through all this discussion here about the margins after wedge resection, but there is a way to do it. And again, ask the patient. We're going back to the Z4032, which was a prospective randomized control trial of sublobar lung resection for cancer versus sublobar and brachytherapy in patients with respiratory impairment, so to speak. And they administered a self-assessment questionnaires for quality of life. What were the responses? Borderline patients have a more pronounced reduction in physical than mental ability. Okay, we know that. But increase in dyspnea after segmental resections compared to wedges, and after thoracotomy compared to VATS. We know that. But there is only a modest increase in physical activity after 3 months from VATS compared to preoperative values. So maybe the self-assessment is not really good in selected patients, but more usable in a generalized population. And establish a preoperative rehab program with smoking cessation. That's what we're trying to do in collaboration with a huge respiratory hospital we have in Naples. It's called the Monaldi Hospital. We looked at subject our patients to a very intensive training pre-op, only to find out that actually the patient who underwent rehabilitation for 2 or 3 weeks presented at surgery and had post-surgical results much better than the group that underwent surgery right away. And consider minimally invasive approach, always. I feel responsible. I came up with the idea of a uniportal some 10, actually almost 12 years ago. But there is something we need to consider. Only for the fact the uniportal VATS is being used more and more in the Eastern country, in the Asian countries. And this is something that's happening. As well as the non-intubated awake surgery. I'm not going to talk about notes because we don't have the material to talk about notes right now. But anyway, very fast. This is what we are heading with the uniportal. There are all different possibilities of expanding this field. We do lobectomy uniportally. But look at this. The reason why I asked to anticipate this talk is because I'm flying to Hong Kong, and this is the program that I'm gonna be part of in Hong Kong. We're gonna talk about non-intubated single port lung surgery, and they're gonna talk about non-intubated coronal resection. So this is something that I would like to give you my perspective on this. As I said, I feel responsible a little bit. And my perspective is summarized by 3 Latin words. Cum grano salis, which means with a pinch of salt. So my conclusions are, we are experiencing in our clinical practice that there are less inoperable patients than before. And I didn't touch on the age scenario. Right now, we have to perform a multifactorial risk assessment of 30-day mortality and morbidity, but the evaluation will have to be soon extended to 90 days, because as Gonzalo was showing, especially after pneumonectomy, the 90-day limit is not enough. The mortality gets to twice the value of postoperative mortality after 90 days. And thank you very much.
Yeah, we've a few minutes for questions. Mr. Rocco has to disappear quickly, but if there's any burning questions, please go right ahead. I think you're on the plane.
Thank you.